Sorry, it's like taking a little long. Okay. Hello, web shadowers. Welcome back. This is our third session for
Sorry, it's like taking a little long.
It is. Sorry.
Hello, web shadowers. Welcome back. This is our third session for Sorry, it's like taking a little long.
This afternoon, we have a pleasure of hosting Dr. Bradley, who will be teaching us about anesthesiology. As always, please remember that the Google form will be posted in the chat and the description of the video when the session is over. With that being said, Dr. Stephen Bradley, you may start whenever you're ready.
All right, let's see. I think this is all set up okay. Hey, everybody, thanks for coming and hanging out. I'm Dr. Stephen Bradley. I'm an anesthesiologist and clinical medical ethicist. Let's see if I can confirm. Hopefully you guys can see the screen okay. Cool. So I'm Stephen Bradley. I'm an anesthesiologist and clinical medical ethicist. During this talk, I really want to expose a lot of you guys to the field of anesthesiology. Talk about some of the cool things that we get to do from day to day in the operating room, and eventually, tell you about my career, how I got to where I am today, and what I experienced along the way. We'll also get to a chat about, what would you expect, whether you're kind of shadowing or going to medical school and getting ready to start rotations. What would people look for in students that are rotating through anesthesia? And then we'll definitely get into a case presentation topic, and I'll kind of talk about how I approach emergency surgical cases. So thanks for joining, and hopefully you enjoy today's chat. So a little bit about myself. Again, one of my goals over the last couple of years has been to help graduate students and pre-medical students kind of find fulfillment, get to where you are and where you want to be in your life and in your career. When you're starting out, there's so many things that you have to accomplish and to get through in order to be successful, quote unquote. Whether you're in high school and you're looking at colleges, I get messages in my DMs on Instagram and social media from high school students that are looking to become anesthesiologists. I have messages from pre-med students that are looking to go to medical school. And one of the goals that I have is to help make people's paths a little easier than the pathway that I had. I had a lot of trial and error, hit or miss, and it's kind of a school of hard knocks. And fortunately, I was able to make it through. But whether or wherever you are in your path, just plug in. We're all on the same train track, essentially, of life. We're just in different spots. So you work hard, and your hard work will pay off. I have a website, Stephen Bradley MD, if you want to know more about me. My pathway to medicine wasn't straightforward. I hadn't been exposed to anybody or anything in the health professions prior to college. I was a Navy brat. I grew up moving up and down the East Coast. And eventually I went to college. I was initially studying music. I love music, play a couple instruments, and my goal was to become a music teacher. And then along the way, that plan changed. Your plans are probably going to change at some point in your life, for better or for worse. So my first exposure to medicine was working in the hospital there in Jacksonville, Florida. It was Shands Hospital. And at that hospital, I actually worked doing construction. And I went with the electrician, the boss that I was working with, and we were changing light fixtures in a physician's office. And I saw the degrees on the wall. And I thought to myself, hey, that's something that looks pretty cool. This looks like a really cool job. Maybe something that I could do one day. That was right after my freshman year of college. I looked into medicine. I wasn't sure if I could do it or not. I kind of took a leap of faith. I plotted and planned out how I would get through the next 3 years of undergrad to finish the coursework required to apply to medical school. So I had a plan in place. So I definitely encourage you all to develop that plan if you haven't already. Also sit down and write down like a 5-year plan and a 10-year plan. I normally don't like planning. I'm not a planner at all. but several key moments in my life, I did develop a plan and was able to execute that plan. After changing my major in undergrad, I was not going to be able to take the medical college admissions test prior to finishing college. And so I wouldn't be able to go directly from undergrad straight to medical school. So I looked around at different programs, and there's quite a few. There's even more now than there were back then. And University of South Florida has a one-year master's program, and that's the program I took part in back in 2009 to 2010. During this program, we did a full anatomy lab. We did pathology classes. We did neuroscience. It was kind of almost like the first year of medical school, and it really helped me learn how to study as a graduate student. As I was at that University of South Florida program, I later, eventually took the MCAT, applied to medical schools, and was accepted to the Howard University College of Medicine in Washington, D.C. I started in 2010. So I was a class of 2014. Along the way in medical school, you get exposed to different specialties. A lot of my classmates knew exactly what they wanted to be when they grew up and finished medical school. I had no idea. I just barely made it to medical school as far as I knew. And so I had a good friend, Brandon. Brandon was super gung-ho about a couple of things. He knew what he wanted in life. He wanted a great lifestyle and wanted to make a lot of money. So first he was like, oh, dude, we got to do ophthalmology. It's awesome. You make a lot of money. You operate sitting down. It's the best. And I was like, I wasn't really great with the eyes in med school. The anatomy of the eyes, the physiology, it just wasn't my cup of tea. So whatever. I was actually looking into family medicine. A couple months later, here comes Brandon again. Hey man, anesthesia is the best. You make a lot of money. You wear scrubs all day. You just hang out in the OR. It's cool. You make a lot of money. I said, all right, well, that sounds interesting. I could get with that. So I made anesthesia a plan B. This was in my third year of medical school. It just so happened that the American Society of Anesthesiologists was having their annual conference in DC that year. So since I was in DC already, I literally walked from my apartment down to the conference center and was at my first ASA conference. It was great to walk around the booths. It was a little overwhelming, but I met, a couple of different programs and learned more about anesthesia. The next year, I, had anesthesia as a plan B. I rotated through different specialties going through third year, and eventually, figured out anesthesia is right for me. I went to another conference, another ASA conference, did some away rotations, and eventually ended up matching at the University of Chicago Medical Center. So I went there in 2018. It's a 4-year residency. Sorry, I went there in 2014 when I finished medical school. It's a 4-year residency program. And that last year of residency, I was actually able to participate in a fellowship in clinical medical ethics. So in addition to my work in the operating rooms, once a week, I'd meet with my cohort and we discuss different ethical dilemmas and ethical cases that would come up on the wards in other parts of the hospital. I rotated through the ethics consult service, and I really enjoyed helping people make these difficult medical decisions. A lot of this came from experiences that I had in the ICU. When I went into anesthesia, my actual goal is to become an intensivist. I really enjoyed the ICU patients when I was in surgery and thought I wanted to be a trauma surgeon, and then realized I could do ICU through anesthesia as well. So that really shifted the course and trajectory of my career. But in the ICU, you get a lot of complicated family dynamics, ethical issues, legal issues. And I really wanted to know what to do in these situations. So I pursued this fellowship in clinical medical ethics. It's paid dividends because I still use it actually today. I'm on vacation from work, but there was an ethics meeting this afternoon that I went in for to discuss this clinically complex case, and was really able to use some of the things that I learned in that fellowship. I still want to be an intensive care physician. For anesthesiologists, we can complete an additional 1-year fellowship in ICU to become intensivist. I wanted to go directly into this after finishing residency. However, I did swear into the Navy during one of their scholarship programs, and I had to defer that for an entire 4 years. So as I wrap up my commitment with the Navy, I plan on going back to do a fellowship. So over the last couple of years, I've been practicing on active duty in the United States Navy. I am an assistant professor in the Uniformed Services University of Health Sciences. So I work with our anesthesia residents in our program here at Naval Medical Center Portsmouth. And I also managed to kind of step out and launch another side project of mine, the Black Doctors Podcast, which is a show that comes out weekly, and it features minority professionals in healthcare, in business, in engineering, and just helps provide some representation for students along the way. These 30 to 45-minute episodes, I just talk with someone in an interesting field and find out, what is your job? How did you get to where you are today? What do you do day in, day out? This picture here, is from my time in the Navy, where I was actually stationed aboard the United States naval ship Comfort, USNS Comfort. It's one of the 2 hospital ships that the Navy has, and it does a lot of health relief work, missions work. On this particular deployment, we were gone for 5 months, and we went to 10 different countries doing mission stops where we would see patients on shore, bring them on the ship. That ship actually has 12 operating room suites. We used 4 or 5 of those, and we would do humanitarian aid type surgeries, hernia repairs, hydrocele repairs, and just help with the local population. So that was in 2019. This is the same ship in 2020 that went up to New York as part of the COVID-19 pandemic response. I am an anesthesiologist. That's why I'm here. That's why I'm talking to you here on Web Shadowers. So what do we do? Anesthesiology is an incredible field. There's a lot that goes into it. If you break it down into 3 main parts, we are experts in providing all types of anesthesia. Anesthesia is without pain. We numb the senses. I say to my patients, I keep you safe and comfortable during the procedure. That's my goal, if I had to break it down and keep it simple. We're also experts in pain management. Even still, we can go on to do an extra year of fellowship training to become pain management physicians. However, during our 4-year residency, we do rotate through a chronic pain clinic at least 2 months, and we also will rotate on acute pain services, which have inpatients who are post-surgical patients that need additional help managing their pain. We're experts in providing anesthesia, we're experts in pain management, and we're also experts in critical care and resuscitation. This is what pulled me into the field. So when it comes to critical care in our residency alone, we do at least 4 to 6 months of ICU time. I did a total of 7 months in the ICU, where I was on and managing patients that were critically ill. These were patients from open heart surgery, heart transplants, lung transplants, liver transplants, kidney transplants, so you name it. And we had a burn unit there at the University of Chicago. So those are kind of the 3 things that anesthesiologists specialize in. This picture here is I was actually just there as well. This is the simulation center at the hospital I currently work at, where we have this high fidelity anesthesia simulator, the sim mannequin. So I'm getting ready to proctor some students in this picture. I was setting up today for a simulation that's going to happen on Wednesday, because I won't be there because I'm on vacation. But this mannequin is so specialized. I think it's at least $100,000 mannequin, if not more. This mannequin gives a blood pressure, oxygen saturation, a pulse, EKG. We can hook this mannequin up to the anesthesia machine and administer anesthetic gas at different concentrations. And the machine will the mannequin will physiologically respond to the medications that we give. We can inject medication. It's a barcode scanner that you scan like a simulated medication, and you can inject that, and the machine calculates how much you gave, and the patient will physiologically respond. Extremely high fidelity mannequin. I can make the tongue swell up so it's hard to intubate. I can simulate seizures. I can simulate laryngospasm, bronchospasm, all these intra-op emergencies. I can even control the lungs independently. The simulation for Wednesday is a hemorrhaging patient, so I can control the amount of blood loss and how quickly it occurs and how quickly the patient's vital signs start to change. So it's just one of the things that I do as an anesthesiologist, as part of my job as an assistant professor of anesthesia and teaching the next generation of anesthesiologists. The incredible thing about anesthesia, there's a ton of variety. So whatever you want to do, there's probably a chance for you to do it. Most people think of operating room anesthesia where you're taking patients back, you're taking out appendixes and gallbladders and doing hernia repairs. So there's your standard operating room anesthesia. Most places have, just tons of operating rooms, and depending on the level hospital you're at, whether it's a tertiary care center, which is super advanced, or a small community access hospital, which is more basic and rural, just provides kind of necessary care and emergency care. These operating rooms are very different. There's hybrid operating rooms where you actually have X-ray machines built into the operating rooms. There's ORs that have MRI machines that are built into the operating room. So all kinds of fancy stuff that happens in these operating rooms. Next, there's offsite or office-based anesthesia. So if you go to the GI doctor and you need a colonoscopy or endoscopy, you may go to an endoscopy center, which is a offsite kind of same-day procedural environment. There's different office-based anesthesia types of anesthesia, whether it's dental work or plastic surgery offices. So you can literally set up your own business and be a mobile anesthesiologist and go to different places to do anesthesia. There's cardiothoracic anesthesia. This is a picture to the right of a open heart surgery. They've done a median sternotomy, so they divided the sternum in half. They have retractors in place to open it up, and there's the heart. This might have been a heart transplant. I don't remember. One of the craziest things about, and some of my favorite surgeries are heart transplants, because for a while the patient's completely on the heart-lung machine and the chest is just empty. And it's something surreal about looking over the drapes into a cavity where there used to be a heart, the one organ that keeps you alive, and it's just gone. It's empty. So there's cardiothoracic anesthesia. That is an additional 1-year fellowship after doing 4 years of anesthesia. You'll learn how to do a transesophageal echocardiogram, which is when you put an ultrasound machine kind of down the patient's throat and it gives you a view of the heart. And then they do really big cases, heart transplants, lung transplants, super sick patients. Some of the best anesthesiologists you'll ever find are cardiothoracic anesthesiologists. They're second only, of course, to the critical care anesthesiologists, who are just super smart because you kind of have a combination between being a medicine physician and an anesthesiologist. You learn a lot of medicine. You've already learned a lot of medicine from medical school and through residency. You do anesthesia, and then you kind of go back to that critical care background. And I'll actually be going back for a critical care fellowship starting next year. I'll spend a whole year rotating through different intensive care units and learning how to take care of extremely, extremely sick patients. If you like kids, you want to work with kids, maybe pediatrics is for you. Pediatric anesthesia is another 1-year fellowship where you learn how to take care of kids. Probably most of the fellowship, you're going to learn how to take care of really, really sick kids, and that's not often what's going on at community hospitals. Typically, they're kind of bread and butter or normal surgical procedures like tonsillectomies and adenoidectomies, and you're taking care of those kind of kids. But if you stay at a tertiary care center or a large urban hospital, there's a good chance you're going to take care of some really, really, really sick kids. Kids getting heart surgeries and other types of problems, congenital malformations. And that's a whole year of training in pediatric anesthesia. Chronic pain medicine, you learn how to do different procedures to help treat patients with chronic pain. Regional and acute pain management. So chronic pain is kind of long-term. You have an office, patients are going to come and see you. You're going to develop plans, whether you're weaning them off of opioids, doing lumbar epidural steroid injections to treat back pain. When it comes to regional and acute pain, these are patients that are coming out of the operating room that are hurting a lot. You're an expert at doing nerve blocks, so you can block probably just about any nerve or any section on the body to help treat that pain and make patients more comfortable. It's how we do a lot of our anesthetics. So if we're just working on a pinky, we can do a nerve block in the arm or in the shoulder, and it makes the whole arm go numb, and the surgeon can operate without having to put the patients off all the way to sleep. So regional and acute pain management is an additional 1-year fellowship where you can go and learn all these nerve blocks, learn how to develop different pain programs and set those up at whatever hospital facility you may end up at. And then there's obstetric anesthesia. So you can do an additional fellowship if you love doing obstetrics. You learn how to really take good care of pregnant women, a lot of the pathology that's involved. Obviously, with obstetric anesthesia, you're taking care of 2 patients at the same time. You got mom and baby, and you really learn how to take care of both patients and do what's best for both parties involved. So not only does anesthesia have a lot of variety, anesthesia is extremely hands-on. It's one of the things that I love about anesthesia, as opposed to maybe some of the other specialties. You do a lot of procedures every day. The kind of common misconception is that we're just intubating patients, and once you kind of get over how new and cool and awesome intubations are, it's okay. Like, it's just a thing that we do, so we can provide surgery. Like, the end all be all of anesthesia is not just being able to intubate. It's kind of expected, and honestly, anybody can intubate after a couple of days, couple of weeks of practice. The beauty of anesthesiology is you're incorporating your medical training through medical school and through residency, and then combining that with learning how to do anesthesia. So you put it all together. Again, you have that anesthesiologist, you have that pain physician, and you have that intensivist kind of all wrapped up into one. And it really allows you to provide this next level of care. Your anesthesiologist is sitting back and thinking about, how do I intubate this patient? How do I secure this airway, rather? Should I do a direct intubation with a laryngoscope? Should I do an indirect intubation with a video laryngoscope? Right now, there's, especially more now than there were 10 years ago, where we have video laryngoscopes where you can look at a computer screen essentially as you intubate the patient, and it really helps improve the success rate of intubations and decreases the rate of complications there. Central lines, large IVs that are going into the neck or the shoulder or the groin to secure access. We're doing nerve blocks, like I mentioned, like the regional and acute pain management. Well, you learn about those nerve blocks in residency, and there's a basic number of nerve blocks that you need to know as an anesthesiologist. So we do those. We are the best in the hospital at securing IV access. It's a closely guarded secret because we don't want to be running around doing IVs. But we use the ultrasound a significant amount and are very capable at placing IVs, even some of the most difficult sticks. We do neuraxial anesthesia, which is your spinals or epidurals. I was actually working last night, so I did an epidural. Provides pain control for labor. You could also do surgery under an epidural, and you can even use the epidural for postoperative pain control. And then transfusion, sometimes you got to give patients blood. I don't really know. I don't remember why I added that as a point, that anesthesiology is hands-on. But yeah, sometimes we give blood products. You're deciding, that's that critical care training. Does the patient need blood? Does the patient need albumin or crystalloid? What is best for this patient? Do they need pressors or vasoactive medications? And let's see, even when you're the Surgeon General of the United States, you still can get your hands dirty doing anesthesia. When I was on the Comfort, the Surgeon General, Dr. Jerome Adams, former Surgeon General, flew out to the ship to visit, and he suited up in scrubs, came to the OR, and we did some anesthesia together. So he's anesthetizing, I think she was 6. Did a great job. It was a pretty cool experience to do anesthesia with the Surgeon General of the United States. Another great thing about anesthesia is that it has the potential for a great work-life balance. I was actually just talking with one of my classmates from residency yesterday, talking about their current job. They just made partner, how much money, is an incredible amount of money that they're making, and the lifestyle that they're able to live. And honestly, when it comes to medicine, there's a lot of people that are burnt out and worried about burnout, and people kind of have a really negative opinion and view of medicine and healthcare as a physician. And I think it depends on what your expectations are. So if you set your expectations appropriately, I don't think you're going to be disappointed. The beautiful thing about medicine and anesthesiology, you can have flexible hours. It's all trade-offs of what you really want. You can work part-time, you won't make full-time money, obviously. But the pay is still good. Pay is fantastic. You have a lot of variety in what you do and where you do it. Me personally, my current practice, I'm at a kind of small tertiary care facility. I have residents that I work with. So a typical week for me, Monday, I might be in the operating room. I'll have a resident, I'll staff cases or discuss cases with that resident the night before. So if it was Monday, Sunday night, the resident's going to text me, call me, we're going to get together, we're going to powwow, and they're going to develop a plan and tell me what their plan is to provide anesthesia. I'm going to say that's terrible. That's the worst thing I've ever heard. Just kidding. This is a teaching moment, and usually they're really good. And then sometimes I was like, well, do you think about this? What do you think about that? What do we need to do to optimize this patient for surgery? And this is a teaching opportunity that we have with the residents. That's on Monday. I come in, we do a couple cases. Tuesday, I might be on the acute pain service where I have another resident and we're doing nerve blocks all day. And we might do 6 or 7 or 8 nerve blocks. And again, it's teaching for the resident. I'm monitoring them like a hawk as they advance these needles under ultrasound guidance next to some very, very sensitive structures, whether they're nerves, blood vessels, or the lungs. And that's my license, right? And my patient ultimately that, I have to make sure is safe the whole time while the resident I'm working with learns how to do these procedures, and talking to them about the plan for anesthesia and what medication do you use for these different nerve blocks and which nerve block will be the best approach for which surgeries. That's on Tuesday. On Wednesday, let's see. Maybe on Wednesday, I might do some pediatric anesthesia. I can do kids down to 1 month. Might do that. And Thursday, I might be the board runner or the guy in charge of the ORs, where I work to make sure cases move efficiently through the OR and find a place for different emergency cases as they come up. And then maybe Friday, I'm on call where I come in at my current practice. I come in the afternoon at 4 o'clock and I'll work overnight until 7 the next morning. So a lot of variety. And then if you don't like that, you can always kind of find another job somewhere else. Maybe if you're not in the military. If you're not in the military, you can find another job somewhere else. If you're in the military, you're kind of stuck until the end of your service obligation. But you can always, at some point, find a job that you like better. Maybe you want to do a surgery center where you're working from 7 a.m. to 2 or 3 in the afternoon. Those jobs definitely exist. There's also academics, which is what I plan to go back to, where there's a lot of complexity, a lot of tough cases. You have residents and trainees that you're teaching how to do anesthesia, great place to learn and to become very good with your practice. Then there's obviously private practice, which can kind of cover all of these. Private practice can cover a surgery center. They can cover kind of a academic center as well. It just depends on what you want. The work-life balance, I think that was from me going on vacation and residency. My brother was stationed in Hawaii, so I went down and visited him. And that's Waikane Bay. As we proceed through anesthesia and the field of medicine in general, it's obvious that we do need more diversity. At the moment, women are half of the medical school graduates and only 41% of the academic anesthesiologist workforce, 25% of the anesthesia workforce in totality. We have underrepresented minorities that are only 10% of medical school graduates, and fewer than 4% of anesthesiologists actually identify as Black or African American. This was a picture of me and my co-residents. I was fortunate because I had absolutely fantastic time in residency. Don't let people scare you. Like, residency was a blast. Trying to think, my buddy John Henry's on the far left, Brandon and Chirag, like we were always kind of up to something. And we were in Chicago, so it was a fantastic time. And we still keep in touch to this day. As I mentioned before, medicine itself needs more diversity. In 2018, the percentages of active physicians by race and ethnicity, over 50%, 56% were white or Caucasian, and about 5% were Black or African American, 6% with Hispanic heritage. And there are studies out there that show, we know that patients typically receive better care or are more satisfied with the care they receive when it's with a physician that they identify with, and there's more ways to identify with somebody than the color of their skin. This is the culture, the community, shared passions or interests, all of the above. But I am passionate about increasing that 5% of Black physicians. And to that end, I have the Black Earth podcast and other endeavors that I take part in. See, those are my classmates from so those are my classmates from medical school. And right there in front is Brandon. He's the guy that kind of got me interested in going into anesthesia. That's Tyrell serving face in the right. It's my buddy Tamario. He was interviewing for residency, and I was at University of Chicago. I think I was in my second or third year. He came to the program, showed him around. He was a great applicant. Everybody wanted him. And he ended up going down to Texas, and now he's in Maryland doing a cardiothoracic anesthesia fellowship. And then this was me during residency. I mean, residency again, like I had a fantastic time. That's my buddy Jarrett. He's a general surgery resident. And my friend Noelle, she's an orthopedic surgery resident. She specializes in pediatrics, and she's in Michigan right now. So again, people talk about residency like it's the worst thing ever. I had an absolute blast. And then every year, the University of Chicago would kind of send us to this huge conference, the Student National Medical Association, which is the largest organization that's focused on getting Black and Brown students into medical school, into residencies. And we were able to represent the program there and meet prospective students and encourage that next generation of Black and Brown physicians. I mentioned it earlier that the Black Doctors podcast is one of the things that I started, or I do try to inspire the next generation of Black and Brown healthcare professionals. It's available on Apple Podcasts, Spotify, Stitcher, other major podcasting platforms. Working on bringing some new stuff. I know I'm getting old and I talk a lot to other attendings, so that folks can log in and say, hey, I want to know what it's like to be a physiatrist or a PM&R doc, or I want to know what it's like to be an obstetrician, or I want to know what it's like to do obesity medicine. So I interview a lot of attendings to find out what is your practice like, what's different here and there. Working on bringing on a resident physician who will be able to provide interviews with his cohort and have kind of something closer to that pre-med resident level where they could share knowledge, ideas, and information targeted towards that community. So stay tuned. If you're interested, check out the show. New episodes every Monday. This week, I'm actually interviewing an engineer. That was pretty interesting. Didn't know much about engineering. Still don't know much about engineering, but the stuff that he said was incredible. All right. I can't see you guys. However, the screen shares, my screen's all taken up. So I don't know if you're there or not. I'm going to keep talking like you're there, and hopefully you can see me, since I've been talking for 30 minutes, and I'll be a little disappointed if I was talking to myself the whole time. Anyways, I'm going to keep going. We're going to get to this case presentation. So this is an emergent case. We have a 24-year-old female who's presenting for an emergent laparoscopic appendectomy. They're going to go in with cameras and take her appendix out, typically because the appendix is infected. You have appendicitis. The vital signs are remarkable for tachycardia. She has an increased heart rate. This is typical when you have an infection. The patient has right lower quadrant abdominal pain, which is typical for appendicitis. She's NPO, that's Latin for nil per os. So she's had nothing to eat for 2 hours. She's 75 kilos, which is a bit of a normal, weight. And then her BMI, body mass index, is 28. So she's a fairly normal sized young lady. Unfortunately, for patients going to have surgery, we want them to be NPO or nil per os for 8 hours after they've eaten a heavy meal. If it's just liquids or just water, you can have those up to 2 hours before surgery. If it's a light meal, which is literally like tea and toast, so no fats or proteins, then that'll be a 6-hour hold before you can have surgery. So this young lady probably, had a cheeseburger and her appendix started hurting, belly pain, abdominal pain, came to the emergency department. They did their ultrasound, their CT scan, and boom, she's got appendicitis. She's got to go. Technically, like the medicine is always changing in terms of when these patients need to go to the OR, but more often than not, we're going to proceed with infection. There's a risk for it rupturing. For patients that we're about to go to surgery, we do a history and physical exam. This is something that you learn in medical school. You'll rotate through different medicine rotations, and you'll use this a lot. And then you'll also use this, surprise, surprise, back when you're doing anesthesia, because again, anesthesiologists are physicians first. And we really take the patient's entire medical history into account when we're providing these anesthetics. So this young lady has a past medical history of asthma, which is seasonal. She occasionally uses albuterol. She does smoke. Her past surgical history is not contributory, nothing big there. Her labs are significant for elevated white blood cell count, signs she's infected. She has a favorable airway and physical exam. I'm going to dig a little deeper into the exams in a second. Some of the things that jump out immediately: asthma, but it's controlled. Yeah, I'm not terribly worried about that. Now she's an active smoker. So when you smoke, nicotine affects the cilia in the lungs, those little finger-like hair structures that move mucus up and out. And it predisposes patients to coughing violently. It decreases the amount of oxygen they can carry in their blood. So it's a big deal. Some plastic surgeons, you can't even smoke if you're having like breast surgery because it'll cause the microvasculature to die and the grafts won't take. So smoking is going to contribute to some of the plan we have for anesthesia. And then her surgical history is non-contributory, which, she hasn't had anything significant. If somebody has a surgical history of a transplant, or maybe they had their jaw resected or something crazy, I'm like, okay, I need to adjust this. Or, they've tolerated general anesthetic before, they've been intubated, etc. What's our plan for administering anesthesia? So when it comes to building this anesthetic preoperative evaluation and plan, again, we're starting with the history and physical. In an emergency, you can boil this history down to 5 questions. What is the patient's NPO status? Are they, did they just eat? Is there a full belly or not? Do they have allergies to medications? Obviously, we don't want to give them a medication they're allergic to. They're going to have a whole list of other problems. Have they had any anesthetic problems in the past? This question is specifically geared towards figuring out if they have a history of malignant hyperthermia in them or their family. Malignant hyperthermia is a very rare event, and it's an allergy to volatile anesthesia gas, as well as succinylcholine, which is a neuromuscular blockade or a paralytic that we use in the OR. I asked them if they have any medical problems. I typically keep that question vague to see what I can get, and not, then I'll go kind of break it down by system. Any heart problems? Can you walk 2 flights of stairs without any chest pain or trouble breathing? That's important because it shows their metabolic equivalence. Anesthesia is about as stressful as walking up 2 flights of stairs with a load of laundry. So if your heart can't tolerate that, then we probably need to get you worked up better before we do your anesthesia. What medications is a patient taking? Because obviously medications have side effects and they have reactions with other medications. So we're going to figure that out prior to going back to the operating room. So usually I'm on call or I'm working with my residents. They'll see. I just go through 1, 2, 3, 4, 5, 5 fingers of, five question history. We're going to do a physical exam as well. A big part is the airway exam, which I've included the simplified airway risk index. One of the big things is the mouth opening. How wide can the mouth open? What's the thyroid distance, which is the distance between the thyroid cartilage and the mentum, which is the kind of tip of the jaw. The Mallampati classification. So if patients open their mouths, and depending on how much of the uvula and other structures you see, that tells you what their Mallampati score is. How well can they move their neck around? That helps know how difficult this intubation is going to be. Do I need to use a fancy light with a camera on it? Can they stick their jaw out? Can they prognath? All these things can kind of go together to predict if this patient's going to have a difficult airway or not. Other things to remember in the physical exam, you want to check the patient's heart and lungs as well. So definitely, I always auscultate the chest and, make sure I can hear it's kind of a sinus rhythm, and I'm not hearing any wheezing or rales or rhonchi or coarse breath sounds that would indicate, they have a pneumonia or are sick, or maybe they've aspirated already. My anesthetic plan for this young lady is 24-year-old female scheduled for an emergent laparoscopic appendectomy. The plan is a general endotracheal anesthetic with rapid sequence induction, secondary to her not being NPO. So when we administer medication to get patients off of sleep, they fall asleep, and that takes out their gag reflex. It also loosens up the sphincters in their esophagus, and this would allow stomach contents to drift up and get into the lungs, which is aspiration. That's why you have to be NPO to have surgery. And it's also why in emergencies, we'll do a rapid sequence induction where we push the meds to achieve intubating conditions in less than a minute, and then we can proceed with securing the airway as quickly as possible. For induction for this patient, I would pre-oxygenate, which is what we do. We put 100% oxygen on patient's face. Obviously, you and I, we're probably breathing 20% oxygen right now, but we put 100% oxygen on, and that's what they breathe for a couple of minutes. It takes out all that other 80% of things that are in the gas or in the air that we breathe. This allows them to be apneic for much longer while we secure the airway. For her, she does not have a history of malignant hyperthermia, so I would administer propofol and succinylcholine. Propofol is a hypnotic agent that causes you to fall asleep. It also causes lower blood pressures and it keeps you from breathing. Succinylcholine is a paralytic, which helps loosen up the muscles and makes it easier to place your breathing tube. For maintenance, for this young lady, I would use a volatile anesthetic and then multimodal analgesia, so just anesthesia gas, and then I give her different medications to treat her pain. I'd also keep her paralyzed since it would be a laparoscopic case. You want her nice and relaxed so they can insufflate and put air into the belly to operate. At the end of the case, we're going to reverse that paralytic, extubate the patient when she meets extubation criteria, and then proceed to the recovery room. It's kind of a basic plan for a fairly basic anesthetic. The last part of today's talk is to talk about how, when you do decide or have the opportunity to rotate in anesthesia, what's the best way to act and how do you succeed? I think the biggest thing that's important for aspiring anesthesiologists is emotional intelligence, being able to read the room, being able to know what people are thinking. Like if you watch the scrub techs in the OR, the ones, especially the ones that know their surgeon, they're going to hand a surgeon what they need before the surgeon even knows they need it. So the anesthesiologist, you develop ears. You're listening for everything that's going on in the OR. I typically know mostly everything that's happening. But that emotional intelligence will help you stay out of trouble, which will help you deliver the best patient care. Other things you want to make sure you're doing is being prepared. Find out what the expectations are for rotations that you may do, whether it's shadowing or whether it's formal rotation in medical school. Some places expect you to see pre-ops of your patients the night before. Some places just expect you to show up and place breathing tubes and that's it. A lot of times you'll kind of figure that out in the beginning, who's interested in going into anesthesia and who's just doing a cool rotation to put breathing tubes in. Oh, excuse me. Be on time. Sure, that goes without being said. If you're on time, you're late, and if you're, something like that. You want to be interested. So there's an art to this because students come in and think that they're just going to ask a bunch of questions, but realize that the person that you're working with is actually working. So whether that's a resident, that's even worse because that resident is still learning how to do anesthesia. Whether that's an attending, they typically have more time, they know what they're doing, but maybe it's a very complex part of the case. So you want to appear interested, but you got to use that emotional intelligence to know when is a good time to have these discussions, to ask these questions, and when should you wait until there's a less critical part of the case. You should work to be helpful, but ask. If you're trying to do things, a lot of people are very, very particular when it comes to anesthesia. Every attending will have their own way to tape an endotracheal tube in place. I don't know how, but we all do. And we don't like it when people do it the wrong way, which is not our way. So I say when you're being helpful, you really want to ask, what can I do to help? Sometimes you can't. And unfortunately, you just have to stand there kind of awkwardly. But it's better to appear conscientious because you're asking for things to do and to help. And they're saying, nah, chill, it's cool. As opposed to one, taking the initiative and doing something wrong. Or two, just coming across as being nonchalant and uninterested. Be personable when you're looking at residencies, especially. They want people that are a good vibe, a good time, they're going to fit in, they're going to work hard, they're going to be smart. So you got to look good on paper as well as in person. And then self-awareness, again, that goes along with emotional intelligence. That bottom right picture is the University of Chicago Medical Center, where I spent the days of my youth. That's the view that we had from the ORs, actually, the back row of ORs looking downtown Chicago. There's the University of Chicago baseball diamond, and you could see the buildings from downtown at sunset. I don't know the entire milieu of the audience, whether you are mostly pre-meds or medical students. I highly, highly, highly recommend for medical students, especially those that are entering the match, to check out the Match Prism app. I know this was kind of new when I came through, and that was many, many moons ago. So there may be better apps out there, but I thought this was a very helpful program to coordinate and collect my opinions and thoughts on different residency programs. So I would highly recommend you look into this if that affects you. So that's going to conclude the presentation, and I am going to stop sharing my screen. I'm going to look over if I can get to YouTube and see if there's any questions there that I can answer. Oh man, there's some questions here. All right. Here we go. All right. Yes, Dr. Bradley. Hey, Christian Gonzalez. Chantel, hello. Ashna, thank you for joining. Patrick, hello. Chantel can see the screen. Thank you, Chantel. Better late than never. And I'm glad I kept going. Maya said you can see the screen. Hopefully, I didn't ask that question too many times. Sarah says hi. Tisha Agunwo, hello. Victoria said phenomenal. I'm sure she means the entire presentation. Amina Amona, hello. My name is Fatima. Wants to learn English. Okay, good afternoon. Does anyone know how long today is? I think it's an hour, so we're coming up in the last 15 minutes. All right, Diani asked, what determined my decision to do the Navy and not civilian life medical care? Do you recommend going to medical school and then the armed forces, or do you think doing it at the same time? So I joined, I think for everybody considering this, you need to figure out your why. Why are you doing the things you're doing? I joined the Navy because my dad's a retired naval officer and my little brother is active duty naval officer. So it was important to me to kind of do the family thing and go serve in the Navy. The military offers a couple of different scholarship programs to encourage physicians to join. I chose the financial assistance program, and I got some stipend money during residency. That was cool. Didn't pay off my student loan, so I do still have some student loans. But it's been an okay experience. Finishing up my 4 years, I'll be done next summer. Some of the drawbacks, I make probably 30% of what a lot of my colleagues are making on the outside. So you lose a lot of money working for the military. But I've had some good experiences. I do actually record some other content. I think I have a YouTube channel that I don't post videos to anymore because I got too busy with the podcast. But I do have I recently set up a Patreon account, the MilMed Patreon account, where I do post occasional videos, or not videos, but audio clips, 10 to 15 minutes long, where I'm talking specifically about my experiences in the military. Patreon, I think it's like $2 or $3 a month or something, but that paywall kind of helps me be able to talk more candidly than I might be able to talk on social media. So that's why that's there if you have questions specifically about military medicine. But that's why I joined. I recommend everybody focus first and foremost on getting into medical school. You can't be a military physician if you're not a physician. So first, focus on medical school. Once you're in, there's going to be a lot of people that are going to throw money at you. By a lot of people, I mean the military and the government. And then you can decide, what makes financial sense for you. I would still recommend probably waiting until you're closer to being finished with your training, and then you can make a more informed decision. Unfortunately, with the military, they're asking people to swear into the military before they're even in medical school. Like, you're signing up for a job that's like 8 years down the road, which is, that's ridiculous. How can Norman ask? Cool. How can you start a private practice anesthesia? So it's a lot of work. Basically, hospitals need an anesthesiologist for their case. You submit a request for proposal. This is how much you'll pay us, and you can kind of start working with that hospital. Typically now, most groups are established, so I'll just find another group to work with, and I'll work in a private practice group. Residency, military versus civilian, it's very different. The civilian world definitely has like a more robust experience. The military right now, they're not really doing transplant surgery. A lot of my residents rotate through different hospitals. I think they spend over half their time kind of rotating out to civilian centers. But it's kind of different if you're, at home base that has everything, or if you're going to different places. You get to learn different systems again and again, and then you don't really know, the attendings, because like I knew my attendings really well because I worked with them for 4 years, but I don't even see my residents. Like, most of the time they're gone somewhere. So I really do try to kind of, work with them and teach them, but it's tough. So that's one of the biggest things that I would say: military residency versus civilian. Military residency definitely has a lot more rules. We had a great time in residency, doing things that you can't do in the military. Maya says, I look happy. It's nice to see such a positive experience. Well, thank you. Despite the oodles and oodles of money I'm losing every day, I think positivity, happiness comes from within. Happiness isn't a place, it's a journey. And you just need to learn to be kind of happy and enjoy the process. And that's definitely what I've tried to embrace. Money isn't everything. It's a lot, though. I love to see the Black representation. I feel even more inspired to continue on. All right, right on. Sarah, thank you. Deani's thinking about diversity. He wants to be a part of increasing their percentages, being a minority doctor as well. Fantastic. What have I found the reason why minorities do not make it into medicine, and how can they be successful or supported better? One of the biggest things is representation. If you don't see it, you can't be it. And then I think it's incumbent on folks that are where I am now to give back. So myself, I have a good group of physician friends, and we make a concerted effort to reach out to students and work with different programs, whether trap medicine, barbershop medicine. My buddy Italo Brown runs those programs, working with the Student National Medical Association. We need to help the youth, I guess. It feels weird to say that. I guess I'm the elderly, but we got to help that next generation get to where we are now. Firmly believe that. Chantel, okay. Chantel Ryan stuck around. Jonathan Ting said, thank you so much for your time and expertise. You're welcome. You're welcome. Kristen Gonzalez, thank you for presenting. Cool. Chantel said, I really enjoyed learning about anesthesia today. Thank you for such an informative presentation. I'll probably skip the accolades, but thank you. Anesthesia stresses the heart, like walking upstairs. It's a heart continuously facing a level of stress throughout the procedure. Yeah, so it's kind of like different parts of the procedure are more stressful than others. It's kind of like taking off from a runway and landing the plane. So beginning and the end are very stressful. Also, depending on the surgery, some are more stressful than others. That's a short answer for that, but it's a longer question. But I think we have like 8 minutes left. What would you recommend for someone who runs to pursue medicine that doesn't have the best undergrad grades? I would recommend getting with a faculty advisor at your current institution to see what you can do to better prepare for graduate school. And then there's a lot of post-bac programs where you can do an extra year or 2 years to help, take some advanced coursework and improve your grades. You can also shadow and gain other good experiences that will help your application. You're welcome, Amy. Maya says, how does an anesthesiologist work with a patient with low blood pressure or hypotension if some anesthetic medications lower blood pressure? That's a fantastic question. It's something that I discuss at length with my resident. So every anesthesiologist, we have a cart full of medication, and it's my job to know what other anesthetic, how else can I keep this patient asleep by using a medication that does not cause low blood pressure. So I know all of the side effects of each medication that I'm using, and I mix and match to achieve an outcome that keeps the patient hemodynamically stable or homeostatic, makes it the same. So a lot of that you learn in residency, and anesthesia is truly an art, and lots of practice. Ashna, you're welcome. Holly, how were you able to find doctors to shadow for anesthesia? So I shadowed in medical school, or I didn't shadow. I rotated as a medical student in anesthesia, and then I did an away rotation at UC Davis during my 4th year. Kushi says they're a first year pre-med student interested in anesthesia. Awesome, great. I'm on social media as well. Stephen Bradley, MD is my Instagram, and then the podcast. I have interviewed quite a few anesthesiologists of different varietals, so definitely check that out. Faith asks, the most exciting thing I've learned about anesthesia while in practice. The most exciting thing that I've learned is, I guess, the importance of a good plan, and how you can take a patient that is a train wreck and extremely complicated and complex and acute and about to die. And because of medical school and residency, I can break that down into discrete aspects that I'm going to address individually and be able to save that patient's life and provide good care. Tisha asked, how is med school at Howard? was fantastic. We don't even have enough time to go into it, but it was a fantastic time. DC was amazing. Loved it. BMI and weight in regards to anesthesia. How would treatment differ from underweight to healthy to obese? So the medications that we use are dosed based upon weight and the kilograms of the patient, total body weight versus ideal body weight. And so off the bat, I'm always calculating, based on how many kilos they are. The larger the patient is, kind of the worse they'll be able to breathe, because that weight's going to compress the lungs, make it a little harder to exchange air at a slightly increased risk of respiratory failure. Underweight people may not metabolize drugs as well. Like if you're anorexic or have other problems, there's kind of a problem with metabolism that's going to affect how they react to different medications. Advice for pre-meds who are aspiring anesthesiologists. Over the summer, I recommend trying to get in to shadow with someone in anesthesia. Highly recommend that. Jasmine, you're welcome. What are some resources I can look into to become a military doctor? There's a couple, like the resuscitationist. He's got an Instagram page. He's an Army emergency medicine physician. I post occasionally about military stuff. Actually, my podcast episode from 2 weeks ago, I told my entire story about joining the military and some of the experiences that I've had. So I have to continue to self-promote, but I did address that on the podcast. That's available on Apple and Spotify for free. And then I do have the MilMed Patreon, which I'm going to be posting more stuff too and answering questions specifically there. For a while, I was having people DM me and I would set up times to chat, but that was 3 or 4 times a month where I'm sitting there with somebody for 30 minutes. And I just can't do that, unfortunately, because I work and have the podcast and all that. So I'm going to start posting it on that Patreon account. That was for Kevin Guraswamy. Lucy C, thank you so much. You're very welcome. Diani, you're welcome as well. Kevin just followed me. Awesome. Yeah. Oh yeah. I do some music stuff. So if you go to my Instagram, you're gonna see some music. I'm not an influencer. I just post stuff that I like, and I'm happy. Maya, I'll probably close out on Maya's question. Do you have any words of advice for a mature student applying to medicine? So it's never too late. Make sure you know why you're doing what it is you're doing. If it's financials, what is a dollar amount? What is a reasonable dollar amount that's going to make it worth your while? Is it worth the stress it'll put on your family? What is the end goal in 5 years and in 10 years? Where do you want to be? Don't be discouraged, because we're all running our own race, living our own lives. We're just on different time frames and different timelines. So do your best to extract value out of every moment of life, which is ridiculous, right? When you have a tough medical school exam, you're not going to be extracting value while you're studying. You're not going to be happy studying for these medical tests and for your MCATs and board exams. Those aren't really happy times. But if you live your life to the fullest when you're not studying for those exams, at least you have some positivity to kind of reflect on, and you get something to look forward to while you're in the thick of it. So that's my words of advice, Maya. So, wow, I'm going to go back over to Zoom. And the folks at Web Shadowers, definitely thank you guys for having me on your show. Hopefully you guys, enjoyed today's talk. I am on Instagram, mostly, and Twitter, Stephen Bradley MD. And then the website is the Black Doctors Podcast. I also have a podcast on medical ethics called Curbside Ethics, so check that out if you're interested. Or the MilMed Patreon account if you want to know more about military medicine.
Thank you so much, Dr. Stephen Bradley, for a wonderful presentation and for answering everyone's questions. Everyone make sure to check out his socials and his podcast. The link today in the Google form will be posted in the chat box and will be posted in the description of the video shortly. Please fill it out within the next 30 minutes for us to receive the verification of your attendance. But thank you.